So what has been our journey of treating heart failure with reduced ejection fraction and heart failure with mildly reduced ejection fraction? Initially, we started long back, 200 years back, with digitalis and diuretics. Then came the time when we thought this was a hemodynamic disease, and we gave vasodilator like isosorbate dinitrate and hydralazine. And the VA studies showed some clinical benefit with regard to reduced hospitalization. Over a period of last 25 years, we moved to standard dual therapy, which was anti-RAS agents, ACE inhibitors, or ARBs plus beta blockers. Both individually showed a significant reduction in mortality and hospital for heart failure. And these were the cornerstone of therapy for a long time, till 15 years back, when a golden triangle was created with anti-RAS agents, beta blockers, and mineralocorticoid receptor antagonists, also called as aldosterone antagonists. This went on till few years back, and that is largely 3 years back, when another member to this therapy was added, and now it was called foundational 4 therapy. That includes A plus B plus MRA plus SGL2 inhibitors. So we have moved from hemodynamic modulation towards complete neurohumoral modulation over a period of time. And right in the wings are drugs like vericiguat and omecamtiv, and we would soon find the niche for these. At the moment, these have very limited role, but I'm sure we will soon find a niche for these in some patients of heart failure. So this is the golden quadruple therapy of HFrEF as suggested by European and American guidelines of 2022 and 2021. 4 corners, anti-RAS agents, which are ACE inhibitors, ARBs or ARNI, beta blockers, MRA or aldosterone antagonists, and SGL2 inhibitors like empagliflozin, dapagliflozin. Right in the center are drugs which have slightly less importance, but they're necessary for relieving the congestion and improving the symptoms and decreasing hospitalization, like digitalis, isosorbate dinitrate, and hydralazine, diuretics, ferric carboxymaltose, because heart failure, 50% of patients have iron deficiency. And I told you about omecamtiv and vericiguat, which are right in the wings, finding their place. At the moment, both have a 2B indication in heart failure, and ivabradine, which is for reducing the heart rate and has a class 2A indication. So the impactful core therapy has 4 corners. On besides the corner, devices should not be forgotten. 40% of the entire European and American population in heart failure treated with devices, ICD or CRT, because they not only they prolong life, they improve the quality of life, especially CRT. But in this country, the use of device decimal is less than 2%. The use of device is going down because of better pharmacotherapy. So what is happening with pharmacotherapy? We can safely say that 50% of the need for devices is going to go down in next 5 years as these new drugs are used more and more. What more is needed for impactful therapy? Decongestion, I said, with diuretics, comorbidity control like diabetes, hypertension, salt and water restriction, treatment of anemia and iron deficiency, better nutrition, vaccination against pneumonia and influenza, palliative care, need for heart failure specialists, fixing mitral regurgitation percutaneously, fixing obstructive sleep apnea, and of course, oral anticoagulation for atrial fibrillation and revascularization in select group of individuals. Now, having told you, let us focus again on heart failure with reduced ejection fraction. And as I said, there are 4 definite class of agents. And all of these agents, whether they're anti-RAS agents, beta blockers, aldosterone antagonists, ARNI, of course, also let us take it another class, and dapagliflozin. All of these cause relative risk reduction mortality from 17 to 34%. And of course, they reduce the hospitalization, anything from 30 to 41%. So obviously, the 2 main mortality and morbidity endpoints are adequately addressed by all these 4 class of agents, and number needed to treat are lowest with beta blockers, ARNI, and aldosterone antagonists. If all these 4 class of agents can be given to patient HFrEF in recommended doses, you can bring down the mortality of HFrEF by 75%, and currently you can bring it down by about 4 to 5% per year from 20%. But the sad part is only 1% of patients all over the world, including India, are on all these 4 drugs. And that is where the clinical inertia, therapeutic inertia plays a role, and cost plays a role, and also tolerance of the drugs plays a role.